All right, thank you for the opportunity and invitation to be here. I have no disclosures. So I'm going to go through the history of optimizing opioid prescribing for surgical patients at Mayo Clinic and talk about our progress to date, and then shift to some opportunities in health services research for long-term follow-up of patients prescribed opioids for acute pain. So way back in 2015 to 2016, which is a long time ago as far as opioid prescribing goes, we at Mayo Clinic started having conversations with my surgical colleagues, and it became clear that surgeons did not know how much to prescribe. There was really nothing in the literature at this point. And we as an institution also did not know how many opioids were being prescribed. So we did an environmental scan that resulted in this paper and found wide variation in overprescription of opioids after 25 common elective surgeries. So we studied adults undergoing the 25 procedures across multiple specialties listed on the right across 3 years in our 3 main hospitals. We studied over 7,000 adults, 75% of whom were opioid naive. Here's the main figure from that paper where we look at oral morphine equivalents prescribed in opioid naive patients across these 25 procedures. And I'd just like to focus on the height of these bars. The black lines are the overall range of opioids prescribed to opioid naive patients within a single procedure, and the blue boxes are the interquartile range. So you can see even within opioid naive patients, we saw a huge variation in what patients were taking home. Also, over 80% of our opioid naive patients were prescribed more than 200 oral morphine equivalents, which was of concern given the state of Minnesota was considering legislation at that time. Again, we saw wide variation within surgical procedures, which was of concern also across procedures, which is likely more appropriate. But we saw an opportunity to standardize and optimize opioid prescribing. So moving on to 2017, and one of the prompts I received for this talk on how should users of clinical practice guidelines be engaged in the dissemination and implementation of the guidelines. I'm going to talk about the Mayo Clinic approach. So what we did in 2017 was develop multidisciplinary teams per surgical specialty. Each specialty had a surgeon champion who was well respected in his or her division or department to be the co-leader with me as the health services researcher. We also had a data analyst, a pain medicine physician, Helena Gazelka, who is on the HHS task force nationally, a nursing administrator who worked closely with that specialty, a pharmacist who worked closely with that specialty, and a health systems engineer who was our quality improvement professional. So we worked both on guideline development and implementation. For guideline development, the bolded roles all participated. For guideline implementation, we counted on the stakeholders who were actively practicing within these specialties, the surgeon, the nursing representative, and the pharmacist, as well as our quality improvement professional, Danny Whipple. So Danny used this ADCAR model for quality improvement. With opioids, ADCAR was off to a good start because obviously there's an awareness of the need for change and desire to support the change. What we worked on was the knowledge of how to change and developing these guidelines to be used in the practice. We then gave the surgeons and the prescribers ability to demonstrate the new skills and behaviors and reinforcement, which came from multiple angles, the surgeon champion, nursing, and especially pharmacy. So this ADCAR model created our framework for consistency and standardization. We always had the underlying goal of prescribing the lowest amount of opioids, the lowest dose for the shortest duration, but also allowing room for tailoring. As we heard earlier, we're really looking at targeting the 80% of patients with tailoring for approximately 20%. So for guideline development, we had a kickoff meeting with each specialty with all of these stakeholders. We would review their historical prescribing based on 10 to 40 CPTs that the surgeon champion would provide from their surgical specialty and discuss the goals, realistic drops in prescribing, and specifically meeting the needs of our patients without introducing or continuing the unnecessary risk of overprescription. Guideline implementation was also tailored to each specialty. This involved a lot of grand rounds presentations, as well as email blasts, resident education, printing out the guidelines and taping them to computers, posters in the break rooms, but it depended on what the specialty stakeholders said would work best for their group. We also focused on who prescribed. This varies across specialty. Very rarely is it the surgeon in our institution. It's usually the resident or an advanced practice provider. We also needed to involve nursing, which we didn't do from the beginning for floor nursing. And as this goes back to something we heard earlier today, where they did not know that we needed to manage this patient's expectations. So when the floor nurses were discharging the patient with a low amount, they were causing concern in the patient. And so we needed to go back and educate them. And then again, pharmacy is very integral to this effort, both educating and re-educating the residents and the script writers, and reinforcing at multiple levels. So I'm going to give you an example from our very first attempt, which was in orthopedic surgery, and we implemented this in our Rochester campus in summer of 2017. This is our first attempt at an opioid prescribing guideline. Dr. Tad Mabry, a hip and knee surgeon, was our surgeon champion for this effort, and he came up with the idea of grouping the multiple procedures into 4 different tiers of prescribing with similar pain profiles. So for example, the top level 1 is for acute fracture or carpal tunnel release, and then level 4 at the bottom includes our total hips, total knees, and spine surgery with fusion. Each of these has a maximum MME of 100, 200, 300, or 400, and the number of pills listed next is a few different options. So after implementation of these guidelines, we saw reduction in standardization of opioids prescribed. Knees are in orange, hips are in blue, pre-guidelines in the solid boxes, post-guidelines in the shaded boxes, and overall we decreased prescribing by 50% in hips and knees. We also decreased variation, as you can see, of the shrinkage of the box heights. Importantly, we always monitor our refill rates, and there was no statistically significant increase in refills for either hips or knees, even though we did reduce prescribing by 50%. We also looked at adherence to guidelines. So before the guidelines existed in 2016, only about 10% of prescriptions for these procedures were at our guideline levels. In the first month of rollout, about 50% of guidelines met, or 50% of prescriptions met guidelines. And then by the next month, it hit 80% and has stayed fairly stable at 80% in the low 80s ever since. Again, this was our target, so we were very happy to see that. So that was going on in 2017, but there was a lot of things going on in 2017 with opioids. And to date, we had been studying only the amount that were prescribed based on our pharmacy orders, but in order to understand the optimal amount to prescribe to our patients, we needed to know how many they were consuming. So we conducted a survey of roughly 2,500 recently discharged Mayo Clinic surgical patients, again across multiple specialties. Our goal was to determine how many opioids patients were using. We already knew what they were being prescribed. So what we did is query patients upon discharge, and the Mayo Clinic Survey Research Center called them 3 to 5 weeks after surgery. They asked them how many opioids they had consumed, if they needed a refill, how easy it was for the patient to receive the refill, their preoperative use, and their patient experience. Patient experience is a very important counterbalance to us, and we were monitoring it multiple ways at all times. In total, over 3/4 of patients had leftover opioids, and over 60% of opioids prescribed went unused. Just in our survey cohort alone, this represented 55,000 unused opioids at the time of survey. And if we extrapolate this to our Rochester surgical population alone, it was over 1 million excess pills prescribed per year. This is the main figure from this study. Each of the 25 procedures is listed along the left. The total width of the bar is the median amount of opioids prescribed. The blue length is the median amount consumed. Therefore, all of the orange that you see all over this chart represents leftover opioids. So moving on from 2017 to 2018, again, we had these multidisciplinary teams of surgeons, pain medicine, residents, nurses, pharmacists, and researchers. We took all of the data we had available internally, data from other groups, including the Michigan group, and the other sources in the literature to develop our specialty-specific guidelines. So I'm going to shift to my second example, which is our Department of Surgery guidelines implemented in February 2018. You can see these guidelines have evolved quite a bit. We still have the procedures along the left, and we have 3 columns of dose options for prescribers. Low dose, which is almost always NSAIDs or acetaminophen only, standard dose, and a high dose. And along the bottom, we have information to help prescribers sort patients into these 3 columns based upon our survey data and multivariable analyses. I know this might be small, but it should be in your handouts. So these launched in February of 2018, along with patient education and provider education as well. So I have a brief unpublished QI data to show you the impact of these guidelines, knowing we had a bit of a delay as we transitioned to a new electronic health record. So pre-guidelines, the median amount prescribed for these Department of Surgery procedures was 150. This dropped to 60 and was statistically significant. This signifies a drop of 20 tabs of 5 milligram oxycodone to 8 tabs. This was very different by procedure. This is confounded by procedure, so we also have procedure-specific information. We also saw standardization of care. The range dropped from 150 to 75. In total, over 50% reduction in the amount of opioids prescribed. We also looked at where on that chart people were prescribing. So we had the low dose, the standard dose, and the high dose. About 21% of prescriptions were at that low dose, 40% at the standard dose, about a quarter at the high dose, and the remainder above guidelines. So again, we're targeting 80% for the guidelines, and we met that as well. So to summarize, implementation of these guidelines in the Department of Surgery, opioids prescribed dropped, variation in prescribing also decreased. Our refill rates remained stable for 12 of our 13 procedures. There was a dramatic spike in one of our procedures that we are addressing right now. We also saw respectable guideline compliance for 12 of the 13 procedures, with a different procedure that we need to focus on for compliance. So in 2019, we have guidelines for postoperative opioid prescriptions that have been implemented across all of our surgical specialties. These continue to evolve. Here are some more examples across a number of different specialties. But as they evolve, they are constantly updated within our internal data area, Ask Mayo Expert. So if someone goes to prescribe 5 milligram oxycodone, there will be links to the opioid guidelines in Ask Mayo Expert with flowcharts for information, patient education, and then specialty-specific guidelines. We also have reports and dashboards available. These are still evolving as we're getting used to our new EHR. So I'm going to shift from the Mayo Clinic experience to more of a health services researcher hat and talk about opportunities for long-term follow-up, which was another prompt from the committee. So what databases are suited for long-term follow-up in patients with acute pain who received opioids for that pain? I'm going to talk about 3 different sources. First, longitudinal administrative claims. Second, Mayo Clinic paneled patients. And third, the Rochester Epidemiology Project. So first, longitudinal administrative claims. Each of these sources has its own generalizability concerns, and I'm sure many on the committee are aware of these, but it also could be a topic for discussion. Examples of these sources are Medicare, of course, military data, and private hospital or insurer longitudinal data that many of us have used, Premier, Truven, or Optum as examples. I have one example of a project that I participated on recently that uses Optum data. For this, we looked at chronic use of tramadol after acute pain episodes in comparison to other short-acting opioids. So for this cohort, we identified over 500,000 patients meeting our inclusion criteria, and the reason I'm highlighting this project is when we're looking at longer-term follow-up, if we look at 180 uncensored days of follow-up, we were able to follow over 400,000 patients. We concluded that tramadol use was associated with a higher risk of prolonged opioid use in patients with acute pain compared to other short-acting opioids. So pros and cons of longitudinal administrative claims data. So there's many things that can be studied with claims: outpatient visits, ED visits, hospitalizations, anything about that hospitalization like length of stay, ICD-10 and ICD-9 diagnoses and procedures, CPT procedures as well. If there are pharmacy claims, we can look at opioids prescribed, opioids filled, and then refills over time as well. However, there's many things that cannot be studied with pure claims. Patient-reported pain scores, HCAHPS, or other measures of patient experience. These are 2 things we study very frequently with our internal data that are not available in pure claims data. Opioids consumed, which, as we've talked about all of the overprescription happening, I think the evidence we're really seeking right now is how many opioids do patients need, and for that we really need good consumption data. Also, non-prescription medications or pain management strategies are not often available or really ever available electronically. And finally, pharmacogenomic data, which I think is where this field going to be going as we look more towards personalized medicine. So moving on to two sources that are more internal sources available for us to follow our own patients. First, Mayo Clinic paneled patients. We have an algorithm where we can look at our Mayo Clinic surgical patients and see how long they are paneled to a primary care provider. And as long as they're actively paneled to a primary care provider within Mayo Clinic, we assume that their health care is being provided by Mayo Clinic, so we can follow patients longitudinally that way. A more unique study or opportunity we have is the Rochester Epidemiology Project. So the Rochester Epidemiology Project aims to improve health globally by studying health locally, and it covers patients in Minnesota and Wisconsin. So the REP has been funded by the NIH for over 50 years, and you can see Minnesota and Wisconsin, Mayo Clinic's kind of right here. And so we have about 60% coverage of this 27-county region, which if you didn't know how rural Mayo Clinic is, that's only about 700,000 records, but it's still a nice size cohort. So the REP is unique in that we have residency timelines for each person living within that area, and we can see whether medical visit dates occurred while this patient lived in the area or out of the region. We can then turn those residency timelines into census enumerations where we can see where patients are coming in and out and build our cohort based only on those where we have complete follow-up or otherwise. So this allows us to both study prevalence and incidence. We also can see linkage across care providers. These are not just Mayo Clinic visits, but also those that occur at our Olmsted Medical Center, other providers, including, I believe, dental providers, and then state and national death records. Type of data include demographic data, immunizations, life habits, biological specimens, medical diagnoses and surgical procedures with ICD codes, drugs, which are very important for this topic today, lab tests, and then all services and procedures using both ICD-910 or CPT codes. So with those three opportunities presented to you today, I look forward to the discussion. Thank you.